Africa, a vast continent, huge countries, long distances with enormous challenges. 70 to 80% of African populations live in rural areas. Medical facilities are few and far between. Infrastructure and road networks are poor. Kenya covers nearly 600,000 square kilometers, about twice the size of the United Kingdom. The East African region is the size of the entire European Union. If you need medical help in this area, you have a problem. Into this vast landscape, in 1957, came three doctors: Michael Wood, Tom Rees, and Archibald McIndoe, with a vision.
The origins of the Flying Doctor service were here in Ormolog, and Sir Archibald McIndoe and Tom Rees came out here in 1957, and we began to talk about the immensity of the problems of bringing health, particularly to the rural areas where 85% of the population live in this part of the world. And after discussing this and trying to find ways of helping the missions and the other services run by the health authorities, we came to the conclusion that one of the first answers should be in the form of communications, and this of course meant the necessity for light aircraft.
And so, in 1957, the Flying Doctors was born. Michael, with his single-engined aeroplane, would fly around East Africa, landing on rough airstrips that were built by the local communities. Flying Doctors visited clinics and hospitals run by missionaries. This was the beginning of the outreach program that still exists today. Severe affliction was common. The number of patients was overwhelming. There were too few beds, too few doctors, too few trained nurses. Technology and medical support equipment had not yet reached this part of the world. Resident surgeons were almost unheard of. Michael could never be sure what medical condition he would find patients in. Operations varied from children with club feet to delivering babies and doing plastic surgery on patients with cleft lips. As time went by, the service expanded, and by 1960, 2 more aircraft had been added. AMREF, the African Medical and Research Foundation, became an international organization that raised funds for its Flying Doctor service. Sadly, in 1960, Sir Archibald passed away, leaving Michael and Thomas to continue their vision. In 1964, Flying Doctors was joined by Anne Spurry, an idealistic and exceptional woman of her time. Born in Switzerland, trained in France, and toughened by imprisonment in Ravensbrück concentration camp. In Kenya, she had a farm in Subukia and a medical practice that went broke when her predominantly white clients fled during the Mau Mau Revolution. At the age of 45, she learned to fly and bought a Piper Cherokee. She took on the job of setting up under-the-wing clinics for the Flying Doctor service at short landing strips in Masai land, miles away in the bush. The Masai, who were nomadic and still very traditional in their culture, were in desperate need of the medical attention that the Flying Doctor service offered.
How long? 2 months. And has he got any other swelling? And this wrist also, knee, general pain in the legs. I've got Samama.
I think most of us would agree that we shouldn't spend too much money on curative medicine, that preventive medicine is really more important. We use curative medicine as a carrot to get people to us in order that we can then start talking about the more important things of preventive medicine, immunization.
Mobile clinics became an integral part of taking preventive medicine to the people. Whilst medical supplies and even facilities for minimal surgery were driven in, doctors would fly in to operate on the patients that would flock to these improvised clinics. Trachoma, an eye disease spread by flies, was a common affliction, and specialists would perform thousands of operations restoring people's vision. Gonorrhea also affected the Maasai, and it was the ability to cure this disease that helped break down the suspicion of modern medicine from the Maasai. Vaccinations against other common diseases such as polio were also administered to as many people as possible.
When I first joined, there was a wooden building, 60 staff, one little 4-seater aeroplane and 2 6-seater aeroplanes. I would say that the flying was probably far more challenging in terms of bush flying, where we used to land more often on roads, etc. With a little 6-seat aeroplane, you had enough room for one stretcher, possibly one accompanying sitting next door to the pilot in the co-pilot seat, which was not something we enjoyed doing at all. And the nurse was sitting, never able to stand, never able to give any life resuscitation to a patient should it be needed. And basically, I would say by today's standards, we are talking of horizontal transport. One of the primary issues was space. We needed bigger and better airplanes. We moved on to twin-engine airplanes, which of course were quite expensive to operate, still fairly limited on space. And the involvement of the turbine engine meant huge cost savings for us. And we moved on into Cessna Caravans, which became a very good platform for an air ambulance, as well as being able to take up to 11 passengers around the outreach, and was able to streamline our outreach programs as a result. The primary reason that the Flying Doctor services exist is to take outreach services to the people of the rural areas of the peoples of Eastern Africa, and hopefully in the future into Africa. Funding for the outreach is mainly raised through AMREF's national offices in Europe, North America, and the Flying Doctor Society of Africa.
AMREF outreach has only 4 surgeons of different specializations, but we use services of more than 200 specialists from university teaching hospitals, from regional referral hospitals in Eastern Africa. We work together with all the big national hospitals, and we get their specialists as frontiers that we pay some little allowances to be able to complement our services. The outreach expansion possibly would not follow the emergency way because the emergency has an element of income generation, whereas the outreach is basically charity. Currently, we would like to expand to Sudan, Somalia, Rwanda, and possibly Malawi.
We are at Riyadh Hospital. This is just on the Tanzanian side of the Kenyan border. Came in the morning. I've just done a surgical clinic. I've got a few patients who are preparing for surgery, who should be operating in the next few days. If you look at the hospitals that we visit, they are quite very far apart from, let's say, from the main towns, the main centers. And to take most, let's say, for example, here where we are, if you have to come by road, I'm sure it takes us more than about a day or two to get to this place, whereas by flight it's just about 45 minutes only. So the offering of the planes gets us to the place where we want to operate within a very short time. These days we said specialists depending on the requirements of the hospital. For example, this time is purely urology. The suspicion I normally get is that was having been around for quite some time. I know that most of the patients, unless you do for them, what we are doing right now is that chances are that it cannot be done anywhere else, meaning that it's either us or nobody. That's our satisfaction. Definitely we change their lives. You know, somebody comes with a problem that cannot be saved. And I talk about this with the confidence, the fact that usually I may come here could be once or twice a year. Some of the patients I've seen right now, most have waited for me for the last 1 year.
Today, the Flying Doctors are also famous for their professional air ambulance service. We rescue patients from the most remote areas in Africa and fly them to places where appropriate medical treatment can be given. If needs be, we are able to transport patients as far as South Africa, Europe, Asia, or the Middle East by private air ambulance jet, all along providing intensive care level on board. The idea of developing a professional air ambulance service was born in close connection with the outreach program. As it is, certain infrastructure for the outreach program, like the aircraft, the hangar, the control room, the pilots and others, is very expensive to run and to maintain, and fundraising for the outreach program has not always been easy. By using part of this same infrastructure, turning it into a professional air ambulance with international standards, we are now able to finance ourselves, and instead of having to raise money to keep the infrastructure going, the outreach program can now actually concentrate on getting enough co-funding for the actual clinics. It would of course be a dream if the Flying Doctor service one day in its entity could become totally self-financing. Particularly talking about Africa, setting up a professional and efficient air ambulance service is not easy and poses special challenges. Distances here are huge, with limited medical facilities few and far between. We are surrounded by political conflict areas, which can make cross-border operations in particular difficult and cumbersome. And we constantly have to keep ourselves updated on what's going on in the countries around us. Our response times to get to the patients are relatively long, and vice versa. We usually have a patient on board for more than 1 hour before we reach the destination of definite care. Patients are often brought to the airstrips in the back of a pickup, and we can never rely on a proper medical report beforehand. The information we get is either inadequate or wrong, and we have to be prepared for all eventualities. Treatment basically has to start as soon as we receive the patient. That's why we always carry a wide range of advanced life support equipment with us to be able to provide intensive care to the patient where necessary. While the aircraft is on its way, the pilot will then relay a medical report to our control center in Nairobi, so that by the time we are landing with the patient, we have not only booked the hospital and alerted the consultant already, but one of our ground ambulances is on standby, ready to receive the patient and take him to the hospital without delay. We always try to update ourselves. We always try to keep in touch with the international air ambulance levels, which means we continuously have to upgrade our medical equipment. The latest addition was a transport incubator. So from now on we are able to also cater and evacuate small babies, premature babies, which before that we were unable to do because of the lack of the equipment. We already had our first evacuation, evacuating a 30-week-old preterm baby from the rural areas to Nairobi, and from what I understand, the baby is doing very well.
The difference between this job and working in a hospital situation or a hospital environment is that, there are no routines. It's a very interesting job that you go using all your skills, the skills that you have learned you've been trained, you've learned as a nurse. You apply up in the sky or on ground when you are with the patient.
It's a very challenging job, and every day is different from the other. It's not kind of a routine job that you're going, every day you're going this way. Every day I wake up, I don't know my next destination, and that's quite challenging, and it's very interesting, and I like it that way.
With the advancement of all the medical equipment we now carry, we needed to consider pressurization. So we have now expanded from the little aeroplanes we talked of in the beginning into a range of aircraft from a Cessna 206 through Cessna Caravans, right up King Airs and Cessna Citation Bravo jets.
The introduction of the Citation Bravo jet opened up a whole new arena to Flying Doctors. Evacuations are now possible at a much longer range, giving access to all of Africa. The variety of the aircraft fleet now operated by Flying Doctors complement each other in such a way that a patient can be retrieved from a bush airstrip and moved on to other long-distance destinations, including Europe, the Middle East, and India.
Longevity is a thing that staff tend to get here. Very few staff move in and move out very quickly. The whole expansion has been through this dedication of an amazing team of people that really do pull together well as a team. And that includes the engineers, the doctors, the nurses, the cleaners, everybody. Everybody works together well. There's lots of smiles, there's lots of laughs. Of course there is sorrow, but the team is what has made it possible.